Thanks. It's good to be back. I'm a regular here. Decent amount of people in the crowd still. Okay. Last lecture of the day. I hope it was worth your stay. Of course, I'm biased. Best topic for last. So let's see. Where's the pointer? I'll need this. That works. Okay. So the focus of my talk today, again, I gave updates in MG talk, I think a couple years ago. I was asked to give more updates because there are more updates. It's very exciting. It's evolving rapidly. So today's talk for me, I will focus a lot on treatments. So if you leave today with more questions than you did coming in, then I did my job. And then these are my disclosures. Again, many of the medications actually that are used first line from MG, the older therapies, are off-label. So those are the medications that I'll discuss off-label. And then all of the other disclosures are not relevant to today's talk. So very briefly, I'll go through the clinical presentation for those of you who encounter myasthenia gravis in your practice. It is a rare disease, despite my patients saying, I thought I had a rare disease. I see it everywhere on the commercials now. So it is a rare disease. The incidence is about between 15 to 40 every 100,000 individuals in the United States. There is a bimodal kind of peak. It's 3 times more common in young women. It tends to be associated more with thymic hyperplasia and elderly men who tend to have more thymic pathologies such as thymoma. Again, any age, any sex can develop myasthenia gravis. It's differentiated by presentation, ocular versus generalized, as well as grouped according to the presence of autoantibodies. The most common subtype, of course, that we see is AChR, acetylcholine receptor antibody positive. This entails about 80 to 85% of those with myasthenia gravis. MuSK antibody is the second most common seropositive myasthenia gravis, and then a small subset of those seropositive patients are LRP4. There is a smaller fraction of seronegative. It's thought potentially maybe there's some better assays that can detect antibodies, and there are newer antibodies that are not quite commercially available that are being investigated in a research setting that are thought to potentially be added to the diagnostic to the lab results. And then, the first symptom onset, as we know, it tends to be ocular. And then within a year, about 80% of patients who will develop generalized symptoms will develop them within the first year or so. But isolated ocular MG, we reserve. You can have ocular predominant MG. And then in order to say pure ocular MG, it can present up to 3 to 5 years beyond the ocular symptoms. The pattern of weakness tends to be proximal, of course, ocular, facial, bulbar, axial. You can have a distal weakness with myasthenia gravis, so extensor weakness. You can have isolated foot drop. That's a more rare presentation of myasthenia, but can happen. Again, fluctuating and fatigable is pathognomonic. So you have this individual that has MuSK MG, they have prominent bulbar respiratory symptoms. These patients are hospitalized more frequently and require escalation of treatment more frequently. And so you can see this, MuSK MG can be misdiagnosed as ALS because they have very prominent bulbar features. And you can see an atrophic tongue, you think of ALS, but there's typically no fasciculations and, of course, none of the upper motor neuron features that you see with ALS. Oh, so let's talk about the immunotherapy treatment options that we have. I'll spend a very brief period of time talking about the traditional therapies. These are our oldies but goodies. Of course, prednisone being first line. It works very effectively, typically a lower dose. Also, in one of the seminal studies that was used where prednisone was used to treat ocular MG, really 20 to 30 milligrams was all that was needed. Of course, you can go up to 40 to 50. Rarely do we ever go above 60 milligrams of prednisone. It's typically effective at lower doses. And thymectomy, of course, for AChR antibody positive GMG has been indicated. It has shown to be beneficial in long-term outcomes in reducing hospitalizations as well as reducing the dosage of medications and increasing the chances of remission, which is what we all hope for. And then we have the other oral and IV options, as you can see here. Azathioprine and mycophenolate are the two most common oral options that we use. It targets B cells and T cells. Azathioprine, CellCept are used, pretty equivalently. Again, it depends on the, country. In fact, the study showed that in the United States, CellCept was the preferred agent. And in Europe, azathioprine was the first choice in a lot of European centers. If you're purists, actually, many academic neuromuscular specialists say azathioprine should be first line because that's what expert consensus and multiple randomized control trials support. However, and the preference is not CellCept. However, CellCept is frequently used and it does work in myasthenia gravis, as evidenced in many retrospective studies where CellCept was discontinued and MG symptoms came back. It is commonly used, and if many of you guys have managed myasthenia, mycophenolate is effective. Tacrolimus and cyclosporin is effective, quite effective. It's not commonly used because it requires a lot more monitoring and interactions with other medications. Oftentimes, when we see patients with myasthenia, again, they have other medical problems, they're on other medications, and just requires a lot more monitoring and has a higher side effect profile, tremors, renal dysfunction. One study showed a pretty high proportion of patients. They did a retrospective study looking back 10 years, and a lot of these patients actually discontinued their medications from the side effects as well as the adverse effects, primarily being renal dysfunction. Rituximab is, kind of plus minus for AChR antibody positive. It is used. The BEAT-MG trial didn't actually show that it had a steroid sparing effect compared to just patients who were treated with steroid alone. It is helpful for MuSK. Many trials have shown that it can induce long-term remission in individuals with MuSK. And so rituximab is quite effective for MuSK MG, and it can be effective for AChR antibody positive MG as well. But the data doesn't strongly, suggest that it's that helpful. So again, as you can see here, most of the standard therapies suppress the B cells and T cells. And so what we have now, again, Plex and IVIG is sometimes used for maintenance therapy. We know that it works for in acute exacerbations and crises, but there are a good number of patients who are on chronic IVIG for maintenance therapy who can't come off their plasma exchange. But sometimes it can be used as a bridge just after they're hospitalized and onto newer therapies. So these newer therapies are quite exciting. Again, they're targeted specific therapies. Many of these traditional therapies, of course, they take a long time to work. There's adverse effects of prednisone or contraindications to using prednisone. You want something that works fast, effectively. So these newer therapies that came out were quite exciting with the literature to support its use, with the randomized control trials showing its efficacy and working quite effectively and fast. So the complement therapies, you can see now currently we have 3 options available, 2 IV and 1 subcutaneous, eculizumab and ravulizumab, as well as zilucoplan, which is a subcutaneous daily injection. And that was FDA approved. That was the most recent FDA approved complement therapy. The neonatal Fc receptor antagonist or FcRn inhibitors, we have 2 subcutaneous options and 2 IV options. Of course, efgartigimod was the first in class that was approved in 2021. It was it's a weekly cycle for 4 weeks, and then the way that the trial was designed, and I'll talk about that in future slides, is that you treat it and then you see when the patient needs to be dosed again, versus some of the newer options that we have, including nipocalimab, which was just approved this year, and the first of its first FDA approved treatment for pediatric or juvenile myasthenia gravis for 12 years and above. And this is a dosing done every 2 weeks. So cemdisiran is one that's on the pipeline. It's a subcutaneous complement inhibitor that's administered every 3 months. So U.S. regulatory submission is planned for the first quarter of 2026, and it's pending discussions with the FDA. So these are some of the drug therapies on the pipeline. So going back to cemdisiran, this is a siRNA that drops the circulating levels of complement, so C5, by suppressing the hepatic production. And then in the NIMBLE trial, which was the phase 3 trial, that they looked specifically at MG-ADL and quantitative measures. They showed that as monotherapy in the NIMBLE trial, there was about a 74% drop in the circulating complement levels. And then they did another study, cemdepose, or cemdisiran and posolizumab, which was the antibody combined, and that dropped the complement, because not only were you dropping the production of complement, but you're blocking the complement as well. That had a 99% inhibition of complement. So you're thinking, okay, if you're blocking more complement, you're going to have better outcomes, right? Not necessarily. The cemdisiran monotherapy numerically scored better across their endpoints. So it showed that you don't necessarily need to inhibit all complement to get a beneficial effect. And then, of course, efgartigimod, there was a subpopulation that was looked at. It wasn't powered to look at seronegative patients, but now the ADAPT-SEREN study is in phase 3, actively recruiting specifically seronegative MG patients. And then there's another complement inhibitor. And then kind of shifting a lot of the newer therapies on the pipeline. Again, we have effective FcRn and complement inhibition, which is the terminal portion of the pathway. But some of these newer therapies, and the ones that are on the pipeline, are specifically targeting more of the proximal portion of the pathway that's leading to the production of the antibody. So I'll highlight a few of these, just kind of speaking about, how we think about treating myasthenia. Should we deploy FcRn and complement at the beginning? Should we do B-cell, T-cell depletion? Which one? There's so many options. Oh my goodness. If you're feeling like Elaine from Seinfeld, you're not alone, because again, there's no algorithm to treating myasthenia gravis, right? So again, I think the most common question is, well, which one do I go with? How do I start? When do I deploy the newer therapies? Do I wait till they're refractory? What role do these B-cell, T-cell, what options do I go with initially? So not to sounds very cliche, but really truly it is individualized. We really are pretty ambitious when we treat myasthenia. Again, many of the patients with multiple sclerosis, again, have to be on therapy for lifelong or decades. With myasthenia, we really aim for clinical remission, pharmacologic remission, and then maybe complete stable remission. And that is possible, again, in a fraction of patients. So again, each person's goals for treating their myasthenia is different, right? They might want more aggressive treatment, knock it out. I don't want anything, or, I'm okay taking a little bit of Tosis or whatnot. So again, having that conversation with patients, what are their goals? What are they aiming to, these are the therapies, these are the risks, and you really have an individualized conversation with them. But I think we can all agree, good disease control with minimal to no medication side effects is what most people want. And then returning to normal and near normal daily activities, work, social engagements. Some people just have horrible memories of when they were in crisis and they never want to go to that again. So they're willing to take some of the higher risk treatments, and some, don't necessarily, they're nervous about their infection risk. They're around a lot of children. They work in a school. they're like, I'm kind of happy where I'm at. I don't want to escalate. If I get to that point, then I can escalate, right? So it really truly is individualized. So this is the MG-ADL score. Many of you guys have seen. Many of you guys are required to document this in your notes now for insurance requirements for some of the newer therapies. But the MG-ADL score is the Myasthenia Gravis Activities of Daily Living scale. It has a pretty good correlation to how the patient is clinically doing as well. Sometimes there's discrepancies. There's a high ADL and the exam looks okay. But for the most part, it's a validated outcome measure. It's used in the clinical trials. Actually, many of the clinical trials have this as their primary outcome measure. And then the secondary outcome measures being, some of the physician-reported outcome measures. But there has been a good correlation between ADL as well as the physician-reported outcome measures, QMG, and then the MG composite, which is a combination of key portions of the ADL with the physical exam. So a minimal symptom expression, when we say that, some of the newer therapies that have, outcome measures reported, you'll see something called MSE, which is minimal symptom expression. That's an MG-ADL score of a 0 to 1. And so the FcRn clinical trial did report MSE, and we'll kind of talk about that. So the post-intervention status is, how is the patient doing after you've done the intervention, treatment, symptomatic, immunotherapy, and how is the patient? So minimal manifestation status, what it entails is that the patient has no symptoms or functional limitations from their myasthenia. You can see a little bit of eyelid closure weakness. Actually, many times in myasthenia, even with well-controlled disease, you're going to have a little bit of eye closure weakness. An MG expert, Dr. Chip Howard said, if you're not getting a little bit of eye closure weakness on your MG patient, you're not examining them appropriately. So that's allowed, and just a little bit of hip flexion. But as long as the patient doesn't have functional limitations from their myasthenia, then they can still be considered to be in minimal manifestation status. And remission, whether that's pharmacologic or CSR, which is the holy grail, is essentially requires the same criteria. However, they cannot be on pyridostigmine because the use of pyridostigmine means that they're still having symptoms. Now, some people are reliant on their pyridostigmine. They're nervous to come off of it. And a lot of times I ask them, they're still taking their pyridostigmine 3 times a day, 4 times a day, twice a day. I say, well, is it out of habit? Do you feel like you're taking it? And sometimes they say, well, I just want to, take it to prevent the symptoms from coming on. And I said, totally fine. But we technically, because many patients are like, well, when can I come off my meds? Am I in remission? I can't label you as being in remission if you're still requiring pyridostigmine or if you're taking pyridostigmine. And quickly we'll know, right? Quick onset, and then it wears off in a few hours. So I just counsel them, if your symptoms come back, you can take it. If not, then that means you're really not requiring it. So how we do it, how we approach patients with myasthenia, they come in with the initial presentation, I typically hit them harder. Again, obviously it depends how much symptom burden they have, but the goal is to get them better and then eventually to minimal manifestation status or remission. And then again, there's no strong data driving how you de-escalate, but a de-escalation trial is recommended. You don't want to keep patients on high dose azathioprine or prednisone 30, 40, 50 for a prolonged period of time without an attempted trial of de-escalation. And some patients might require immunotherapy lifelong, but there should be a de-escalation trial, whether that's just a reduced dose of their steroid-sparing immunosuppressive agent or their maintenance therapy or their sub-Q or their IV treatment. Typically, we try to attempt a de-escalation. I love this picture. It's my favorite one. It really kind of highlights the pathogenesis of AChR antibody positive MG. And so as you can see here, the newer therapies are really kind of targeting this part of the pathway. So upstream, what you're seeing here is the B cells. And of course, there's T cell regulation that's happening in the thymus too. So, you want Treg cells, but there's a drop in Treg and an increase in the Th1 and Th17 cells that are cytotoxic. So the thymus is a kind of a factory of B cells. And so that's why kind of earlier in the diagnostic journey, removal of the thymus leads to better outcomes because you're removing that factory of B cells that's leading to the pathogenic AChR that's circulating in the blood. And then a vast majority of the IgG1 that is AChR antibody actually comes from long-lived plasma cells. So you can see upstream here that the newer therapies are quite effective. They target the terminal part of the pathway, but then here upstream, the pathogenic antibody is still being produced. So I guess when we think about treating myasthenia, again, as we said, the goal is get the patient better, but then are there meaningful ways we can induce a true remission, minimize the use of medications in the future? Because patients are asking, well, what are some ways that I can come off my medicines, or what are some ways I can go into remission? Because we can, I can continue these meds forever, but then at some point, how can we successfully de-escalate? So that's kind of the newer therapies, and the ones that I'm going to talk about on the pipeline are really targeting kind of this proximal part of the pathway. And there's a role for each. And so I'll kind of talk about that. So MuSK antibody, again, doesn't activate complement. It's IgG4 mediated. IgG1 and IgG3 activates complement. So this is IgG4 mediated. Again, the B cells are producing the pathogenic antibody. So as you can see here, FcRn inhibitors do target circulating autoantibodies, but you don't see complement here, and there's no role for thymectomy in individuals with MuSK-MG. So let's just kind of summarize what the current C5 inhibitors are. Eculizumab was the first that was approved in 2017. It's IV. It's a weekly loading dose for 4 weeks. Then at the 5th week, you get the higher dose, and then every 2 weeks. Ravulizumab is kind of engineered to be longer acting, so the maintenance dose is every 8 weeks. A majority of patients are, ultimately on Ultomiris now. Every 8 weeks is much more convenient than every 2 weeks. And they both showed, quite significant improvements in the MG-ADL score from baseline to the 26-week mark, as well as significant improvements in the quantitative MG score. So 4.6 improvement compared to a placebo of 1.6. And then in the Ultomiris group, 2.8 compared to 0.8. And in fact, the Champion trial showed kind of the longer you were on ravulizumab, you had an improvement in your outcome measures as well. But then the improvements happened quite quickly when patients were initiated on complement inhibitors. There's a rapid drop in complement, and usually at about 4 weeks, you can see there's a rapid separation between placebo and the treatment arm. Pretty well tolerated headache, upper respiratory infection. And then zilucoplan is subcutaneous. It's a small molecule peptide. As you can see, it's 40 times smaller than IgG. It's 3.5 kilodaltons compared to the monoclonal antibodies that are 148 kilodaltons. So if you have a patient who's getting plasmapheresis or is on IVIG therapy, you can co-administer zilucoplan. And the data shows that this is also beneficial in improving outcomes. This was 12 weeks. The RAISE MG trial showed that at, really the clinical improvements began at 1 week, but then once it started to reach statistical significance was around 4 weeks. And they actually maintained it for 12 weeks. So you can see, again, here's the placebo arm, here's the zilucoplan arm. So there was a significant improvement in the ADL and the QMG. Of course, there are other outcome measures, but I'm just kind of briefly highlighting the ADL and the quantitative MG portions. So of course, one of the other questions is, well, if I'm having IV access issues, or if I'm already on ravulizumab or eculizumab, can I switch over to subcutaneous? And is that safe? Am I going to have clinical deterioration. So this is something that was actually looked at, and we enrolled a few individuals from our center into this trial. Again, it's a small N, and keep in mind the patients who are electing to go into this we're already having a selection bias, because several of the things that they wanted to look at was, did the patients prefer sub-Q over IV? What were the treatment-related adverse events or treatment emerging adverse events? That was the primary outcome measure. So 16 patients switched from eculizumab and 10 switched from ravulizumab. And there were 73% of patients, again, very mild in severity. And treatment emergent adverse effects doesn't mean that it directly correlated with the medication. Some of them were like fatigue, and one was another kind of non-specific thing. And they were, vast majority of them were deemed not related to study drug. And then as you can see here, again, it was supposed to be a non-inferiority study. So the purpose of this wasn't to directly compare the IV to the sub-Q option. It was just to say, is it safe to do so? And do patients have clinical deterioration with that drop? And the short answer is no, they don't. There was an improvement in the ADL and QMG from baseline. And then there was a there was a clinically meaningful improvement in the ADL and QMG scores that were observed at week 12 from baseline from those patients who switched from ravulizumab. And then 77% of patients did prefer sub-Q injections. Again, this is not to say that sub-Q is better than IV, but just that in certain individuals, they did prefer this because they had poor IV access, or they didn't like the, having having to go to an infusion center if the home option wasn't available. So really, again, options are nice to have for our patients. Of course, meningococcal vaccines are necessary. You have to be vaccinated at least 2 weeks prior to getting C5 inhibitors. And then here's the vaccine schedule. If you have to start complement inhibitors immediately, I think some people have been in those scenarios where they have really bad MG and, their Plex is not getting them off the vent. In certain scenarios, in certain institutions, you can get the IV complement inhibitors in the hospital. So if you have to start it immediately, you can provide antibiotics and administer the vaccines as soon as possible. Interestingly, the CDC data suggests that the meningococcal vaccines provide likely incomplete protection against invasive meningococcal disease, but nonetheless, you're still supposed to vaccinate. So now switching over to FcRn inhibitors, this is the newer one that was just approved this year. And just as a refresher, how do FcRns work? It blocks to the neonatal receptor, and essentially IgG has a long half-life, and it's recycled into the circulation. And it's because it evades lysosomal destruction through that Fc receptor. So when you block that, then it marks it for lysosomal degradation. So it drops the half-life of all immunoglobulins significantly to a few days. So nipocalimab, again, enrolled patients of seropositive patients, AChR, MuSK, and LRP4. MG-ADL score had to be 6 or more, and they did show that there was a clinically significant improvement in the ADL score again. And then adverse events were similar between the groups. Going to the other FcRn inhibitors that we have available, again, efgartigimod and efgartigimod alpha. This is a sub-Q injection that's done quickly over the 30 to 90 seconds compared to the IV that's done weekly for 4 weeks. And then again, the next dosing cycle is typically determined by the patient. Now, the clinical trial data doesn't necessarily match up to real world experience. In my experience, and I don't know if you guys have had the same, patients are really requiring that repeat cycle as soon as possible. The clinical trial data showed that they could wait like a couple of months post, prior to their initial cycle. But in my experience, and many of my colleagues at other academic centers, at last meeting I had with them, many did discuss that they are requiring the use of a cycle as soon as possible. But the data was pretty impressive. You can see here that 68% of AChR antibody patients that were treated with FcRn reached that primary endpoint of that ADL score improvement compared to only 30% on placebo. And then one of the things I mentioned, remember the minimal symptom expression. So again, if your MG-ADL is 9 and you go down to 7, that's still a high burden. But this trial showed that 40% of patients that were treated, an average ADL score of the individuals that were in the clinical trial was 9. It dropped their MG-ADL score to minimal symptom expression being a 0 or 1 in 40% of patients. So again, pretty effective therapy. And the sub-Q trial essentially was a non-inferiority study, and it matched up with its IV counterpart. It did show that it was quite effective and pretty rapid. You can see the MG-ADL score improvement happens pretty quickly. Headache and nasopharyngitis were the most common adverse events. And then rosenolixizumab is a humanized IgG4 antibody Fc fragment that enrolled a pretty decent number of MuSK patients. About 10% of their cohort were MuSK MG patients. That specific cohort actually did really well. AChR antibody patients did as well. And you can see kind of same thing here, the improvement in ADL score from the placebo with the adverse events being pretty mild in most individuals. So I want to talk about some of the exciting new therapies that we have. CAR T is, a hot topic in MG and autoimmune diseases in general. Some of you guys might have flinched when you saw this because this is typically used for cancer treatments, and it can be pretty heavy duty. But this is really exciting to us in the autoimmune field, and it's been suggested as a possible cure with, again, a one-time cycle treatment. We don't know that for MG yet, but essentially what happens for CAR T is you collect your own T cells. So you go through a process called leukapheresis. Patients' T cells are collected, and then they're genetically modified. So the T cells are modified to express a CAR. So this is chimeric antigen receptor protein. It recognizes and binds to those specific autoantibody producing B cells. So it goes and it's harvested, you grow the T cells, and then you give it back to the patient. And so now it has this CAR protein that goes and specifically targets the BCMA of the B cells. And so once that's done, you monitor them closely in the hospital, and then long-term monitoring to see if they need to have a repeat cycle or not. So how does this look in the clinical trial? So there's the Cartesian study that looked at this. The primary objective of this was to look and make sure that it was a safe option. And then, of course, secondary objectives to look at the MG disease severity and biomarkers. They're actively recruiting right now in their phase 3, but I will highlight this phase, the phase 1b/2a study. It was a weekly infusion for 6 weeks, and patients did pretty well pretty quickly. You can see that there was an improvement in the MG-ADL score by about 6 and the QMG by about 7. So that's a pretty big improvement in the quantitative MG scale, as well as the MG composite score, and then the quality of life. And one of the things that is concerning, I guess most people have understandably concerns about, is cytokine release syndrome and ICANS. And in this clinical trial specifically, there was no dose-limiting toxicity, cytokine release, or neurotoxicity. So the treatment, CAR T for MG, is thought to be a little different. You're not spilling as many cancer cells and releasing as many cytokines. There was one flu, one drug-induced urticaria, and one NSTEMI that was deemed unrelated. And then no patients, this is important, no patients showed any evidence of functional immunosuppression or disappearance of any of their prior vaccine titers. Again, this is going to target those specific B cells that are producing autoantibody, and then no opportunistic infections and no need for empiric antibiotics. A couple of more that I'm going to fly through. The MINT trial was, inebilizumab. It was phase 3. This did show an improvement, same thing. And this is thought to target, again, rituximab. The reason why it doesn't lead to sustained reductions in antibody is probably because it's targeting CD20, and CD19 inhibitors are going to target target a broader B cell lineage, plasmablasts and plasma cells. And as I mentioned, plasma cells, the long-lived plasma cells, are the ones that are making a lot of the pathogenic antibody. So, by targeting a broader B cell lineage, it's thought to actually drop the dominant source of IgG that's circulating in the blood. Now, plasmablasts are what make most of the MuSK antibody. And then telitacicept is, was looked at in this phase 2. The AAN actually just had a poster in April that showed the phase 3 data that matches up to this. In fact, looks better. They changed around some of their outcome measures and their entry into the clinical trial to be a little more stringent. So the outcomes actually were, much better when compared to placebo. But this is an exciting B cell targeted therapy as well. It's a novel recombinant fusion protein that targets BAFF and APRIL. Again, just different parts of the B cell. And they saw the effects at 3 months and at 6 months as well. And they were able to reduce the prednisone in the open label portion of the study. That's one of the key things that we want to do with treatment is, are we able to reduce the steroid dose successfully? And you can see the patients minimal, so the post-intervention status, those who were improved, dropped, and there were more minimal manifestations. And then you can see here the improvement in the specific muscle groups that were better with MG. We are actively recruiting for CAR-T. We just had our site initiation visit yesterday for telitacicept, so we're excited to get these going. We've already screened a patient for CAR-T, and he has from the neurological standpoint, successfully met the criteria, and we're hoping he meets the criteria from my oncology colleagues. So just all of that to say, again, the landscape for MG is rapidly evolving. Targeted therapies, optimizing. Again, there's broad immunosuppression. There's more targeted therapies. Again, so many options. Which ones do I choose? What role do the newer agents have? How long do I continue them? Which one do I choose? Complement or FcRn? We really, combo treatments, are they safe? Are they effective? We really are treating based on symptoms, clinical status. We don't have good biomarker data to drive these decisions, but to be continued. And we have to be mindful of the cost of a lot of these treatments. Some discussions of, these should be first line now. Well, prednisone and the older agents still work quite effectively. So what role do the newer agents have, and when should they be deployed? So with that, I want to finish. If you saw that picture at the very beginning of the slides, they were made by this wonderful artist, Gina Brody. She was diagnosed with MG. It fueled her artistic exploration and her kind of breach with mortality. She's had a lot of wonderful exhibits. These are kind of some faces that she's also created some artwork. A painting and video installation titled "Are You Okay?" So I think, all these molecular profiles of MG and treatment targets, I think we always want to keep in mind the wonderful, wonderful individuals who are suffering with this disease, and keeping them in mind and being excited to offer them these treatment options. And again, I'm motivated every day to be better for them. So with that, I'll conclude. Thank you.